the University of Liverpool, and I've been asked to give a talk on paediatric emergencies today. So we're going to go through some gastroenterology emergencies and also the febrile child and infectious diseases. I will just keep asking a few questions as we go through, and if you just want to put answers in the chat, the committee can read those out. And then there's also a few MCQs and we'll put polls up for those. So hope you enjoy. So these are the topics I'm going to cover today. So I thought these were the most emergency ones of these topics. So for gastro or surgical emergencies, appendicitis, intussusception, Hershburns and pyloric stenosis. And then a bit on febrile child, febrile seizures, and then meningitis, sepsis and Kawasaki disease. So first up, the gastro ones. So appendicitis, first of all. So acute appendicitis is acute inflammation of the appendix. It's commonly caused by obstruction of the lumen of the bowel by a mucosal swelling or a fecolith. This can also progress to perforated appendicitis. This is where the inflammation becomes more extensive and causes perforation of the bowel, and this is where you'd have more systemic symptoms. So the presentation, so it begins quite a central, vague kind of abdominal pain, which comes and goes. It later moves to the right iliac fossa as it begins to irritate the peritoneum. So that's when you can localise it as in the appendix area. It then becomes constant and severe and tends to be aggravated by movement. Some children may also get nausea, a reduced appetite, and some may even vomit, but the pain is the key symptom to be looking out for. If you do get perforated appendicitis, you're looking for things like systemic illness, so the temp might be over 39 degrees, a fast heart rate, or the child may have signs of dehydration. On examination, you would find tenderness over McBurney's point, which is 1/3 of the way from LACES to the umbilicus, and that tends to be where the appendix is found. You would also get some localised guarding and generalised guarding if there's peritonitis going on. So before we bring up the investigations and management, I just wanted to ask, if you've got a young girl with appendicitis, so sort of teenage girl, what's the first investigation you're going to do, even if you're completely sure it's appendicitis? So if you just want to pop your answers in the chat.
Lots of people are saying beta HCG pregnancy test.
Perfect, yeah. So that's just a good one to remember. Any fertile female that comes into A&E with abdominal pain, even if you're pretty sure you know the diagnosis, you should always do a pregnancy test first. So in terms of blood, you're going to look for raised white cells, a raised CRP, so your inflammatory markers, and the U&E may show significant dehydration. You should always do pregnancy tests in a girl of pubertal age, so over about 12. And an ultrasound doesn't necessarily diagnose appendicitis, but it might rule out any differentials you're thinking of. The management is mainly surgical. So an open or a laparoscopic appendicectomy, so just removal of the inflamed appendix. If there's perforation, you should also think about giving IV antibiotics. If the child is less acutely unwell, you can manage conservatively and sort of watch and wait, give them IV fluids to resolve the dehydration, but generally you're going to be removing the appendix. So it's particularly common for children to get complications of appendicitis that adults wouldn't necessarily get, and that's because they often will present with perforation. So they might get infection, a pelvic abscess if the infection spreads, the dehydration that we've already talked about, so the U&Es are really important, and obviously giving the IV fluids, and some may get bowel obstruction due to adhesions from the surgery. But prognosis is generally very good and most children fully recover. So before we move on to the next topic, we're just going to do a little MCQ to test your knowledge. So you're a junior doctor in A&E. A father brings his 12-month-old son. He tells you his son has been in a lot of pain today. On further questioning, he tells you he's had episodes every 20 minutes or so since this morning. When he looks in pain, he cries and he draws his legs up to his chest. Between each of these episodes, he's well. He also had a small amount of blood in his stool this morning. Given the likely diagnosis, what is the definitive management of this baby's condition? So these are the options if you guys want to have a think about it. And there's a poll there. Answer. Perfect. So the majority of people are that this is answer C, so rectal air insufflation. So the reason for that is because the classical symptoms of intussusception are the pain with the drawing the legs up to the chest and being completely well between those severe episodes. So that's intussusception we're thinking here, and the definitive management of that is rectal air insufflation. So we'll go on to talk about intussusception now. So this is where you get invagination of a segment of the bowel, so a more proximal segment invaginates into a more distal part. It's generally idiopathic, but it is seen more commonly in the winter and the spring. So there are thoughts that it might be associated with viral infection, given that that's when children get those. It's most common between age 2 months and 2 years, and it's more common in boys than girls. So the most common type is in the terminal ileum, but it can occur anywhere. And it can cause occlusion, ischemia, and necrosis of the bowel, so it can be quite severe. So as we described in the question before, the child will have sudden colicky abdominal pain in bouts that occur every 10 to 20 minutes. So they'll suddenly be in pain, they'll draw the legs up to their chest and generally be screaming because they're in a lot of pain. But then between those episodes, they're completely well. Other symptoms are pallor, vomiting, and as we talked about before, the young boy had a small amount of blood in his stool. That's often described as red currant jelly stool, so that's kind of a little phrase to look out for in exams. And again, they could be quite systemically unwell, so they might be dehydrated, tachycardic, lethargic, and you can sometimes palpate a sausage-shaped mass, and that is commonly in the right upper quadrant. And again, as we said, it might cause necrosis and perforation, so they may present with sepsis-like symptoms. So this one, similarly to appendicitis, you're going to get your raised inflammatory markers, your electrolyte derangement because they're dehydrated, and if they've significantly bled with the blood in the stool, they may have some anemia as well. So your gold standard investigation for this is an abdominal ultrasound, and that will show a sign which is sometimes called the target sign and sometimes called the donut sign. So I think I've got a picture of that there. So if you see the red circles on there, are showing you how it looks like a donut. And you can also do an abdominal X-ray, which may show signs of small bowel obstruction, but obviously that could be any number of things, so that's not your definitive diagnosis. So management of this, your priority is to give fluids and antibiotics because these children can be quite sick. So we've talked about the rectal air insufflation already, but that's not your first priority. You need to think about the fluids and antibiotics, especially in A&E. And then you would get them to radiology, and it would be a radiologist that would perform this rectal air insufflation, and that's the definitive management for this condition. If that's unsuccessful, surgical management may be needed, but generally the air insufflation works. If this is untreated, it can lead to ischemia, necrosis, hemorrhage, perforation, peritonitis, hence it being really important that you resuscitate the child first of all. So mortality is 1%, so a bit more severe than appendicitis. And this is generally because those first priorities haven't been done quick enough. Okay, so the next one is Hershburn's disease. So this is a congenital absence of the ganglion cells in the nerve plexuses that innervate the gastrointestinal tract. It generally begins at the internal anal sphincter and it extends proximally, so it's the far end of the bowel that's affected. It affects about 1 in 5,000 babies. Again, is more common in boys and is very common in Down syndrome babies. So in your exam MCQs, if they're talking about a Down syndrome baby and there's bowel problems, this is one to think of. Does anyone know the most common presentation of Hershburn's?
Delayed meconium is what people are saying in the chat. We've got constipation, steatorrhea, meconium ileus.
Yeah, really good. Okay. So as a neonate, it generally would present very early, and it would be, yeah, failure to pass meconium, so severe constipation basically, so there's just nothing at all. So if the baby gets to 48 hours of age without passing anything, then this is what you're going to be thinking of. They may also have abdominal distension, obviously, because they're very constipated, and there may be some bilious vomiting. On examination, a DRE would cause a release of air and faeces because it would decompress the bowel. It can actually present later, so it might not be picked up quite as young, as just severe constipation and faltering growth, but generally you would notice it in the first 48 hours of life. Does anyone know the gold standard diagnostic tool for Hershburn's? So the main investigation you're going to want to do.
We've got biopsy of the bowel.
Yeah, perfect. So yeah, your investigation, your gold standard for diagnosis is a rectal biopsy, and that will show you this absence of ganglionic cells, which is what Hershburn's is. You may also do an abdominal X-ray and contrast studies, but it's the biopsy that's going to definitively diagnose it. So management is decompressing the bowel, and you do that by using regular rectal washouts, or you can form a colostomy or ileostomy. But then to definitively manage it, you need to surgically remove the aganglionic segment, else this is just going to continue happening, basically. So again, there may be some complications, so enterocolitis, fecal soiling, or chronic constipation. So in that rarer later presentation we talked about, this child would just present as constipated and failure to thrive, basically. But generally prognosis is good. Once they've had the surgery, they can live relatively normal lives, but they are quite unwell before that. So second MCQ before we move on to the next topic. So you're a GP, a worried mother brings her 6-week-old baby boy to see you. She tells you he has vomited after feeds for the past 3 days. This morning this worsened because the vomit became projectile. On examination, you find a mass in the upper abdomen. What's the diagnosis that you're thinking of here? Yeah, really good. So almost everyone got that. Pyloric stenosis, well done. So the reasoning for that is that this baby boy's got vomiting, which gradually worsens and becomes projectile. So it's that projectile vomiting that you're looking out for, and tends to have an upper abdominal mass. So yeah, that's pyloric stenosis, well done. So it's a gradual thickening of the pyloric muscle. and it eventually results in complete gastric outlet obstruction. So any food the child takes in is just not getting any further, so they're vomiting it back basically. So these babies tend to be they're feeding a lot, they're very, very hungry, but they're not putting on any weight because it's just not going anywhere basically. It's most common in firstborn boys and those with a strong family history as well. So it generally presents at around 2 to 8 weeks of age with non-bilious vomiting, which gets worse and worse until it becomes projectile. So as we said, the baby will be very hungry, but they'll fail to gain weight. May also be lethargic and constipated. So the baby will be very thin because they're not gaining weight. They'll look dehydrated. There may be some gastric peristalsis, and tends to be an olive-shaped mass, which is in the epigastrium. So that's another one to look out for in exam questions. Does anyone know on your blood results for pyloric stenosis, there's like a classical picture that you might see? Does anyone know that?
We've got metabolic alkalosis.
Yeah, well done. So it's metabolic alkalosis, and you also get hypochloremia, so low chloride, and hypokalemia, so low potassium. And that's just because you're vomiting so much gastric fluid that everything's low effectively. So it becomes alkalotic because you're vomiting up the gastric acid. So you need to regularly do the UNEs to check that these are resolving themselves. You can also diagnose this by using a test feed. So you feed the baby, and then once they've fed, you should then be able to palpate the mass in the epigastrium as this starts to happen. If that's positive, you don't need to investigate any further because that's the only thing that it could be. But if that doesn't show you the result you're looking for, you would do an ultrasound to confirm the diagnosis. So it would show you a thickened pylorus, and the fluid wouldn't be passing any further. So management. So again, like we mentioned earlier, you're going to be focusing on giving them fluids and resuscitating these children because you want to correct those electrolytes. So you give them a bolus straight away and then just maintain. You may also insert an NG tube to decompress the stomach, but then surgical management is the end goal basically. So you're going to do a pyloromyotomy, which is the definitive treatment, and you can do it via an incision in the right upper quadrant or a supraumbilical incision. So complications, as we mentioned, most of these babies get an electrolyte imbalance and dehydration, so you need to concentrate on giving them their fluids. And then obviously surgical risks, which obviously would happen from any surgery, so bleeding, perforation and wound infection. Prognosis is generally very good. Again, like Hershburn, once they've had the surgery, there's no further complications. And they can be discharged 1 to 2 days later. Okay, so now we're moving on to our second main topic, so the infectious diseases. So this is your third MCQ. So a father brings his 5-month-old daughter to see you in the GP surgery. He says she has had a temperature for the past 24 hours, the most recent measurement being 39 degrees Celsius. The baby cries for most of the consultation, but has a strong cry. On examination, you note crackles on the chest, a heart rate of 140 and a respiratory rate of 65. You make a decision to send this child straight to hospital. What reason in particular have you decided to send them straight to hospital? So is it because their temperature is high? Is it because of the continuous crying? Is it the crackles on the chest? Is it the heart rate, or is it the resp rate? Okay, great. So the majority of you got that. So just to explain why it's not the others, so quite a few of you said temperature over 38. So that is really concerning in a baby under 3 months. So any baby under 3 months who has a temperature of 38, regardless of what else they've got, you send them straight to hospital. But this baby's 5 months, so it's not quite as worrying. Continuous crying is fine because this baby's got a strong cry. If they had a weak cry or it was high pitched, we'd be a little bit more worried. Crackles on the chest obviously can be concerning for infection, but they're not a reason to send straight to hospital. The heart rate is okay. It's a little bit high for this baby, but it's not concerningly high. So 90 to 120 would be normal in this age range, so 3 to 6 month old. So 140 is a little bit high, but it's not awful. But the rest rate over 65 is the reason you're sending them. And that's because any child, regardless of their age, if they have a rest rate over 60, that's a reason to send the child to hospital. So I'll just show you now this list of reasons to send the child to hospital. So in a febrile child, so for whatever reason, there's certain things you need to look out for. So first of all, when a child comes into the GP surgery or into A&E with a fever, these are the questions you're going to be asking mum and dad. So how long have they had the fever? Have they taken the temperature? That should say taken, sorry. And then sort of specific symptoms of specific illnesses. So do they have a rash? Do they have respiratory symptoms? Do they have diarrhea or vomiting? And then just looking why they might have picked up infections, so foreign travel, contact with anyone else with an infectious disease. And then the really, really important one is the child their normal self? So mum and dad obviously know the child best, and if they think that they're not well, then you're going to take that as a worrying sign. So these are the things I was talking about before. So this is the NICE guidelines traffic light system, which is used for just identifying illness in a child regardless of the cause. So if they're green, they're pretty low risk and they're probably going to be okay. If they're amber, probably can manage it in the GP surgery, might be observing them a little bit, might ask mum to bring them back if they get any worse. But red, you're going to send them straight to hospital. So I'm not sure if you can read them all, but some of the key ones to think about as a red traffic light are if the child's like pale or blue, if they're not responding to like social cues from parents or from you, that's quite worrying. As we said before, a weak cry is more worrying. And then any child with a rest rate over 60 should go straight to hospital. And an under 3 month old with a temperature of 38 degrees is really quite worrying as well. And then obviously just signs of specific illnesses, so non-blanching rash, neck stiffness that you might see in meningitis, which we're going to come on to a little while. So that's just a key piece of guidance to know about, really. You don't necessarily need to memorise it, but I'd maybe get familiar with the red ones, because you obviously if you see those children, you're going to want to send them straight to A&E. Okay, so if you decide you can manage this child in GP, they've got a fever, maybe you're not sure why, but they don't seem too unwell, you're going to give them some antipyretics, so paracetamol or ibuprofen, if they're particularly distressed, to try and get that temperature down a bit. You also might want to give them fluids, especially if they look dehydrated. It's good to remove any excess clothing or blankets to cool them down a bit, but you shouldn't use cold water baths or ice, that's not recommended. And then safety netting, so this is especially for like the amber criteria where you think they're probably okay, but you want the parents to keep an eye on them. So you should be telling the parents that if they develop any of the following, they should either bring them back or go straight to A&E. So if they're getting things like seizures, non-blanching rashes, the parents specifically think the child's getting much worse, and there's a fever for more than 5 days, or the parent is particularly concerned about looking after the child, you're going to take that as quite a worrying sign. So I've just got here just some general causes of febrile illness in children. This is by no means an exhaustive list, it's just a few of the common ones to know about, and especially for exams. We won't dwell on it too much, but just a few key features of certain diseases there. So measles, this is a red-brown maculopapular rash, looking specifically for the 3 C's, so cough, coryza and conjunctivitis. And then Koplik spots is classical of measles, and they're tiny white spots on the buccal mucosa in the mouth. This is obviously preventable with the MMR vaccine, and can result in some serious complications if untreated. So obviously very important to recognise that. And then just a few more to have a look through. I won't dwell on them all now, but you guys can get the slides after so you can have a look at that. So febrile seizures. So as we said before, if you send a child home with a fever, a seizure is one thing you're going to be telling mum and dad to look out for. So these are quite common. They occur in children between 6 months and 6 years, usually with a temperature of 38 degrees or above. But you can't really find a definitive cause for them. So there's no neurological infection, there's no particular metabolic imbalance. The child's usually quite tired following the seizure. So these can occur in a few different types. So most common, so 80%, are simple. So they're just a generalised tonic-clonic seizure lasting up to 15 minutes. Can be quite scary, obviously, for the parent to witness, but you should reassure them that this isn't indicative of epilepsy, and it's not, it's quite common. It's, and it can just be resolved by reducing the fever. Complex or atypical, so these last over 15 minutes, or the focal seizures, or they keep recurring along with the same febrile illness, so you think there's something a bit more complicated going on, and there are possibly reasons to send the child to hospital as well. And then status epilepticus, so by definition this is over 30 minutes, but actually any child that you can't resolve their seizure after sort of 5 to 10 minutes, you're thinking it's going to become status epilepticus. And again, that's a reason to send the child to hospital. So if you're not too worried about them, you just manage them in the GP. So you just protect them from injury with cushioning, obviously remove harmful objects from nearby so they don't hurt themselves. You shouldn't restrain the child. After the seizure, just check your airway, put them in the recovery position, so usually basic first aid. If you think it's status epilepticus, so it's lasting more than 5 minutes, you can give them rectal diazepam or buccal midazolam to try and stop the seizure, and call 999 at that point. And you should also measure the blood glucose, because this could actually be DKA, and obviously in children it might be that they've not yet been diagnosed with diabetes if they're going to go on to have type 1. So it could be their first presentation of diabetes. And then if they're less than 3 months old, so any child less than 3 months old with this, you can't find an obvious source of the fever, or there's any of those red traffic light criteria we talked about before, you're going to do what's called an infection screen, and you're going to do that in hospital. So anyone got any ideas the sort of tests you're going to be running an infection screen?
Someone's put LP, lumbar puncture.
Yeah, okay.
We've got urine dip, sputum culture.
Yeah, perfect. So you're going to do all your cultures, so blood, urine, stool. Yeah, you can do a lumbar puncture. You need to check that there's no reason not to do certain contraindications to that, but as long as the child's not got those, that's fine. And then you just your basic inflammatory markers, so FBC, CRP, UNE, ABG, and then you might want to do a chest X-ray as well to find the focus of the infection. So another MCQ for you. So a father brings his 11-month-old baby to the GP surgery. He tells you she has a fever and has noticed she seems floppy. He also thinks she's more irritable than usual and hasn't been feeding well today. On examination, you notice a purpuric rash on her legs and it doesn't blanch. You suspect meningitis. If you are correct, what is the most likely causative organism? So is it group B strep, listeria, Neisseria meningitidis, strep pneumoniae, or Cryptococcus? Fab. So a lot of you got that it was Neisseria meningitidis, which is correct. Just talk through why it's not the others. So a few people said group B strep. So group B strep and listeria are both common causes of meningitis in babies, but tends to be neonates, so less than 3 months old, and that's because that's the kind of things they would get transmitted from the birth canal. So this baby's probably a little bit old for that. Neisseria meningitis is the correct answer, and that's because this baby has a purpuric rash that doesn't blanch. So we would describe a non-blanching rash with meningitis as meningococcal disease specifically, and that is caused by Neisseria meningitidis. Strep pneumoniae, a few of you put, is probably the most common cause of meningitis in general, so not a bad answer, but just wouldn't have the non-blanching rash with that one. And then Cryptococcus is a fungus, and that's quite rare, really. Okay, so now moving on to meningitis. So this is acute inflammation of the meninges, which surround the brain and the spinal cord. It's a neurological emergency. It can rapidly kill within hours if untreated, so really, really important to pick up. And even when treated, it can be quite, it can make the child quite poorly and have complications. So causes can be all sorts of things. So it can be viral in actually 2/3 of cases, so quite common to have viral meningitis. So the most common is enteroviruses, and they're self-limiting, so you don't need to worry about getting any rapid treatment for those. And then just things like EBV, adenovirus, varicella zoster, CMV, measles, mumps, HSV. So most of those are rare. HSV is very rare but very severe, so it is one to keep an eye out for in case it is that. Reasons to suspect that would be if they had recent contact with someone who has known HSV, if they had altered behaviour or mental state, basically, if they had seizures, their LFTs were deranged, or they were severely unwell. Those are all reasons to suspect HSV, but it is very rare, so it's probably not going to be the case. Bacterial, so as we said before, group B strep and listeria are common in neonates, so if it's an under 3-month-old, you're probably thinking those. You can prevent group B strep in the being transmitted in the birth canal by giving prophylactic antibiotics if mum is known to have group B strep. Strep pneumoniae is the most common cause in children that are a bit older. Neisseria meningitis, as we talked about before, is meningococcal disease specifically. That can cause sepsis and a non-blanching rash, so that's the one where the child gets really sick. And then TB can cause meningitis, but that's rare in the developed world, so probably not something you're going to see working in the UK. Fungal, so Cryptococcus, is rare but can quite commonly occur in immunosuppressed individuals. So if you know that a child has immunosuppression, that's one to look out for. So it presents as a classical triad with fever, headache, and neck stiffness. So in your exam questions, they're going to be the symptoms they're telling you about. But it is important to know that babies present quite differently to older children, and that tends to be because they can't really tell you what symptoms they're experiencing, so it's more observing for things. So if they have that high-pitched cry we were talking about before, they have a tense fontanelle, their tone is reduced, they have spells where they stop breathing, so apneas, they're lethargic, irritable, not feeding very well, so just generally unwell, that you might think meningitis, and then obviously looking out for your non-blanching rash. Older children so tend to be more with the classical triads. They also might get photophobia, so they can't look at bright lights. Again, they might not be feeding very well, poor urine output, confusion, muscle aches. So these are going to be more things that the child can actually tell you about. But again, most important to look out for the non-blanching rash. So this is the rash we've been talking about. So there's just a few different images of it there. So it's like a purpley rash, and it doesn't blanch when you press on it with glass. So I'll just let you look at those for a second. Okay. So to investigate a child with meningitis or suspected meningitis, you're going to do your basic bloods, so FBC, UNE, LFTs. Remember, LFT was a reason to, if they would arrange, was a reason to suspect HSV, so that's particularly why you're doing that. CRP, blood culture, viral PCR to check for a viral meningitis, and then looking for signs of sepsis, which we're going to move on to in a second. So things like lactate and a blood gas. A CT scan you don't always do, but if there's focal neurological signs or there's evidence of raised intracranial pressure, that would be an important one to do. A lumbar puncture is used to confirm the diagnosis, and then if it's bacterial, determine which bacteria for antibiotic sensitivities, and it can also tell you about the length of treatment dependent on what organism it is. So if you're working in a GP surgery and a patient comes in and you're pretty sure they've got meningitis, obviously you're going to send them straight to hospital. But before you do so, you should give them a single stat dose of IM benzyl penicillin before sending them. And that doesn't matter, you don't need to know about which type of meningitis it is. You should just do that anyway and then call 999. Then in hospital, obviously you're going to go through your normal ABCD assessment, give them fluid boluses because they might be quite dehydrated. Then once you've found out what's causing it, if it's bacterial, they tend to give IV third generation cephalosporins for 7 to 14 days. And this will obviously depend on your trust guidelines. So you should look out for how they treat, what antibiotics they treat meningitis with. But 7 to 14 days IV is the key things to remember. If they're under 3 months, you should add amoxicillin because that will get rid of listeria, which is a common cause in a neonate. If HSV is suspected, so those reasons that we talked about before, antivirals would be given. And then corticosteroids, you shouldn't give them to babies under 3 months, but in older children, these are thought to reduce the chance of hearing loss, which is a common complication of meningitis. So that's to prevent the long-term complications rather than to actually cure the meningitis. And then meningitis is a notifiable disease, which means you need to report it to Public Health England, and household contacts of that child are going to require prophylactic antibiotics as well. So sepsis. So this is quite similar to adult sepsis, everything I'm going to tell you, but there are just a few bits to remember for peds. So this is life-threatening organ dysfunction due to a dysregulated host response to infection. So in a child, this would often occur alongside meningococcal disease, so the Neisseria cause of meningitis. So the child may have a fever, poor feeding, miserable, irritable, history of a focal infection, vital signs going to be off, so tachycardia, tachypnea, low blood pressure. May have that Pyloric rash if it is meningococcal disease, and they may go into shock or multi-organ failure. So just generally unwell, really. They can also be hypothermic, even though you'd normally think infection, so high temperature. You do need to watch out for hypothermia because that can particularly be a sign of sepsis in children. So that doesn't really occur with adults. So that's just one to remember for peds. And that kind of is a more worrying sign than hyperthermia. So then you just assess for sepsis like you would in an adult. So the Q-SOFA, you need 2 points out of these 3. So if they have any 2 of these 3, you're thinking sepsis. So if their systolic blood pressure is less than 100, if they have an altered mental status, or if their rest rate is over 60 in a child, sorry, so over 22 would be an adult. I'll change that on the slides. So management, so you're going to get them to a paediatric intensive care unit if they're in septic shock. Shock is when they have fluid refractory hypotension. So you've tried fluids and their blood pressure is still low. So you need to have tried fluids to determine that. They have a mean arterial pressure under 65, or their lactate is over 2. If they've got any of those, you should be sending them to intensive care. And then, like with an adult, you do your sepsis 6. So I like to remember this as take 3. So take blood cultures, FBC and lactate, and take their urine output regularly, and then give 3. So give them fluids IV, give them antibiotics IV, and oxygen if their SATs are below 94%. Okay, so finally, Kawasaki disease. So this is when I talked about before, if the parent noticed that the fever was lasting for 5 days, that you're thinking Kawasaki disease if the fever's more than 5 days. Does anyone know any of the other features of this?
We've got people saying strawberry tongue, conjunctivitis, cervical, peeling rash on palms.
Perfect, that's nearly all of them, well done. So this is the most common systemic vasculitis in childhood. It's an acute febrile illness involving the small and medium arteries, and is most common in children between 6 months and 6 years. So to diagnose this, you need a fever for more than 5 days, like we said before, and you won't have a clear focus of infection, so you won't be able to put that down to anything else. So you definitely need that, and then need 4 of the following 5. So bilateral non-purulent conjunctivitis, so that would be in both eyes. Mucositis, so this is the dry lips and strawberry tongue, like someone said, so that's good. I'll show you pictures of these on the next slides. Cervical lymphadenopathy, yep. And then changes to extremities. This is often described as desquamation of the hands and feet, which, like you said, is peeling of the skin. And a polymorphous rash as well, which I'll show you a picture of in a second. So this vasculitis can affect the coronary arteries, leading to aneurysms, which can rupture. So it can be really quite serious complications. So it's really important to get this treated urgently. And these aneurysms can leave scar tissue, which causes myocardial damage. So if this occurs, this can be a lifelong problem. So to prevent that from happening, we need to treat them quickly. So we give them high dose aspirin for several weeks. This is one of the only reasons why you would give aspirin to a child. So it wouldn't be given in any other case. There's a syndrome that I can't remember the name of. Raise. Pretty sure. But yeah, aspirin, if you're giving aspirin to a child, you're thinking Kawasaki, because there's no other reason to give it them really. And IV immunoglobulins as well. And then you follow up with regular ECGs and echo, because obviously you're wanting to avoid this coronary artery aneurysm happening. So you need to keep an eye on that for several weeks to check that that's not happened to this child. But as scary as that sounds, it is good prognosis if you treat it quickly. So as long as you can recognise those features and give them aspirin and IV immunoglobulin, then they can be absolutely fine after it. So these are some of the pictures of things I was talking about. So the conjunctivitis, so just the reddening of the eyes, which obviously could be any number of things, but combined with these other features, you're thinking Kawasaki. The strawberry tongue, this is the polymorphous rash, so it can be all over the body. So it's widespread, and it's got various different lesions within it. And then you get swelling, erythema, and the peeling of the hands and feet, and your fever for more than 5 days. Okay, so these are the things I've used for my presentation, and that's everything. Does anyone have any questions? If you pop them in the chat, I think